And it's excellent to see so many of you here. I thought this would be a popular webinar because I know neurology is really tricky. And I've got Jackie, who's one of our faculty members and recently sat her PACES, and she'll be kind of walking you through some of the basics, which I hope will be useful. But as always, I'd just like to kick off by talking a bit about our course. And for those of you who don't know me, my name is Shoaib. I'm one of the organizers behind the BitePACES course. I'm based at Guy's in St. Thomas's Hospital, and I sat my PACES exam back in 2019, so quite a while ago. It was kind of like before the clinical consultation, etc., and when it was station 5. But I have a passion for teaching, and hence why I launched this course. And we have two variations of the course, both in September and October, and we have either a 1-day or a 4-day option. And I think what really makes us unique is the kind of volume of patients that you see. And I'd like to think that our patients are data-driven, so we know what our candidates have seen in the past. We've had hundreds of candidates go through our course in the last year or so. We know the sort of things they've seen, and then we try and mimic similar cases in our courses. And we have small group teaching, so no more than 2 at the bedside, with a course tutor at every patient to really give you tailored feedback. And having spoken to some of you recently, I think what we're trying to do this time around is try to give you even more feedback in time with the patients, because sometimes I think, at courses you can feel a bit rushed. But we're trying to optimize that as much as we can. And if you attend this webinar, you are welcome to a £20 discount if you use this code. Please sign up to our WhatsApp group. That's where you can find out all about our free webinars. And this is actually the final one in our series, but if there is interest, we can certainly do more over the coming weeks. And the top right will take you to our PACES course website. So that's www.bitepaces.com. And again, don't take my word for it, but we have very positive reviews. So here are a few on Google and Trustpilot, having taught several hundred over the last year or so. This is the last in our webinar series. So we've covered clinical consultations, we've covered cardiology, respiratory, and now neurology. And I also did one on general preparation tips. But if you guys feel like you would like to continue these webinars, then just drop us a message in the WhatsApp group. We can maybe hold another poll and see what sort of things you guys want covered. But without further ado, I'm going to hand over to Jackie. So I'm going to stop sharing my screen. And Jackie, whenever you're ready, you're welcome to start sharing.
Hello, good evening, everybody. Can you hear me and can you see me?
I can hear and see you.
Perfect. So let me just try and share the screen. If you bear with me. Okay, and can you, let's have a look. Can you see my screen?
I think it's just loading on my end. I can't see the slides just yet. Oh yeah, there we go.
How about now? Perfect. Okay. So hi, everybody. My name is Jackie. I've just finished IMT 3 and I'm currently doing a trust grade infectious diseases registrar at Charring Cross. And as Shoaib just said, I've recently sat my PACES. So last November. So it was the first day of the new brief clinical consultation. And so by no means am I a neurology expert. However, I have just sat PACES and I've done a lot of teaching and bedside teaching at my trust, and also I've done a lot of neurology, well, just PACES revision in general. So I'm going to bring you the tips and everything that I've learned and the main points that I've gathered from my revision, and hopefully it'll be helpful for you guys as well. So we're going to go through some examination tips, going to go through the main categories, how we were going to, go through the examination and then present it and make some sense of what's going on. And then some brief overview of common stations and some general tips, but won't cover ophthalmology this time. So main category. So, neurology is very stressful. I found neurology very stressful as well. I was like, okay, how am I even going to try and learn all of this? It's so much, and I'm not a neurologist. So from what I've been taught in all of my revision, the easiest way is to break it down into categories and think about what are the sort of common stations that they can bring. So it must be a patient with signs. You're not going to take a history. You've only got 6 minutes, and then it must be something that's very, very stable. It's something that people can come again and again to the exam. And when we think about the category, so when we look at the patient, we can already think of, well, what are our differential diagnoses, and we can break these down into the main categories the patient. So the main categories that we're going to cover are the upper motor neuron, lower motor neuron, extrapyramidal, cerebellar, and cranial nerves. So the majority of the cases that you're going to see are going to be within these 5 categories. And I think if you've got a good notion of that whilst you're examining, you're thinking, okay, it's this upper motor neuron and lower motor neuron, then we've already got a sense of your differentials, how you're going to present it, etc. So you're already in good stead once you've thought about whether it's going to be in these categories. And it makes it easier for you to break down, instead of like all the millions of things it could be, just break it down into these 5 categories first. So the caveat is that some may overlap. So for example, in motor neuron disease, it could be both upper motor neuron and lower motor neuron, but then that can help. You're seeing, oh, it's both upper motor neuron and lower motor neuron. Or, for example, in multiple sclerosis, you might find both upper motor neuron signs and cerebellar signs, and then that can help you to bring it down even more to the diagnosis. So some general examination tips when doing neurology. So always stabilize above joint when testing the power, because you want to test the power of that specific muscle group. So for example, if you're testing, the wrist, then always stabilize the elbow, making sure that you're only testing the wrist, because otherwise, it might seem that they're very, very strong, but actually they're also using their elbow joint as well as their wrist joint. And always think, is it very easily overcome? Can it be overcome by gravity? So, if they're thinking that even if you try and if you ask the patient to, lift up their hand and they're not lifting up their hand, why don't you lift up the hand and then see whether they can hold it there? And then that can help categorize even more the weakness and the power. Again, another thing that when you're testing the tone, so think about the different tones. So, I'm sure we all know how to do very good examinations. So we think about when we're doing testing, for example, the upper limb, whether you're testing for a spasticity, which is more the rate of the movement, and rigidity, which is the increased tone, but that's throughout the whole thing. So spasticity is more like the rate and the velocity and the amplitude, and that's more significant in pyramidal signs, whereas rigidity is more extrapyramidal, where it's throughout the whole movement. So for example, the lead pipe or the cogwheel, it's rigid throughout the whole, and that would be more extrapyramidal. Don't forget gait. That is really, really important in lower motor neuron, lower limb examination. Always, and I would always start with the gait, just so you're not forgetting it. So I would say, okay, lovely to meet. If you're sat at the end of the bed, then I would ask them to walk first, and then we can go on to the lower limb examination, because it's so important. And also, practice is key, and I will say that again at the end, but be sure to give clear instructions to the patient, because I'm sure the patients have already probably done this loads and loads of times. They've probably been examined a lot and they've come to a lot of exams, but just make sure that you're giving clear instructions to the patients, because there's lots of coordination, asking them to do this and do that, etc. So just to show that you've practiced it a lot and you know what you're saying and look confident, then make sure that you're giving clear instructions. So as I said before, that when you look at the patient, you should already be thinking, okay, what is this? And seeing whether you can get the diagnosis. And inspection is so key. And even if you take maybe like 5 seconds at the end of the bed, look at the patient, looking for any wasting, contractions, you might even see fasciculations, looking at their faces, looking for any cranial nerve palsies, looking for any ptosis, whether it's symmetrical, asymmetrical, etc. whether you can see any extra signs such as any walking aids, wheelchair splints, and those are very hard to see when you're like, when you're very, very stressed and you're just like, okay, I'm gonna go straight into the exam. So just take a breath at the end of the bed, look around clearly and see, okay, they've got a wheelchair there. Oh, here they've got a splint there. Which side is a splint? Is it a left leg or is it right leg, etc. And that can really help you to think about the diagnosis and think, okay, I'm probably looking for some weakness, etc. And looking for, even any extra things that you might see, like peg tubes or a long-term catheter, for example. And I think even for my patient, for my own exam, I stood at the end of the bed and I was very, very nervous. And then I just saw very, very briefly some neurofibromas. And then I was like, oh, okay, that's helped me settle down a lot. So, inspection is really, really key. So something that I've learned for upper limb exam was that, we learned how, inspection, tone, power, etc. But there are some screening tests that you do, which you don't necessarily do in the exam. So in like practice, but for PACES, this can be very helpful to help us differentiate the diagnosis. So what I've learned is if they've asked you to do an upper limb neuro examination, what you do is you ask the patient to stretch out their hands and close their eyes and check for pronator drift. And then you open their eyes and then you ask them and you push their arms down gently and always obviously tell them what you're about to do so that they're not worried, they're not stressing, because, you lose marks essentially if you make the patient worried or scared, or if you hurt the patient. And then you push them down, and then you see whether there's any rebound phenomenon, and that would indicate cerebellar deficit. And then you ask them to close their fist. I don't know whether you can see me in the video. Close the fist and open them out as quick as you can. And if it's very slow, then it indicates myotonia, myotonic dystrophy. And then when they put their hands out like this, you ask them to just stretch their hands up like this, and then you feel their back and look for any winging of the scapula. And then when you're at the back, when you're feeling the back, have a look and see whether there's any previous scar from any cervical surgery, myelopathy. So that's a very, very quick exam where you're essentially just asking them to, hold out their arms and do some movements. It'll take maybe 10 seconds, and that's very, very helpful for trying to get the diagnosis as well. So in neurology exams, this differential diagnosis is key because once you've categorized the patient, so you're like, okay, this is an upper motor neuron deficit, or this is a lower motor neuron condition, then you can think about, okay, but what are the differential diagnoses? And what I've learned for, learning these neuro diagnoses is the surgical sieve is key. So I'm sure everybody might have their own ones, but this is the one that I've learned, which is the surgical sieve, which is vitamin C, D, E, F. And I think it's a really, really good one because it covers a lot of things, and then you can really think through it very systematically so that you're not missing anything. And obviously you can change the diagnosis depending on what you think is more common. So for example, peripheral neuropathy I think diabetes is more common, so you don't have to go, okay, vascular infection. However, if you've got this in your head and if you think about, okay, this is the presentation, these are the findings, then what are your differentials, and you don't want to miss any, then having a surgical sieve such as this is very, very useful. So now we're going into the categories. So the upper motor neuron. So if you think about upper motor neuron, I always think about the pathways, and I find that that's a bit easier to think about what could be going on. So if you think if the upper motor neuron pathway is going from the cortex to the brainstem to the spinal cord and into the anterior horn cell, and then when you're thinking about the symptoms, so what are the findings or the signs, then that's when you can think about, okay, so what is being affected. So for example, if it's hemiplegia, then you're thinking it's the contralateral cortex. So, for example, in a stroke, where it's the right-sided findings, then you'll think about the left-sided cortex being affected. If it's monoplegia, then it's more likely to be ipsilateral cortex. If you're finding paraplegia, so that'll be from the bilateral thoracic cord, and that's normally T2 to T12. And if you do find paraplegia, then you must find a sensory level. So you look for this, obviously you'll be doing the motor and then the sensory exam just to localize the lesion. So it could, so you would be doing checking to find a sensory level. And then tetraplegia, so that would be very, very, very uncommon in a PACES exam, but that would be more higher up, so it would be the cervical spine and the medullary lesion. And then for in upper motor neuron as well, we would find, patients might have contractures and they might have disuse atrophy. And as we've mentioned before, so increased tone, so hypertonia, so you might find spasticity, rigidity, and clonus. So this would be in the event that you've been asked to do a lower limb exam. And then you would find weakness in a pyramidal distribution. So it would be weak upper limb extensors and weak lower limb flexors. So even if you've just been asked to do a upper limb examination, you could also say, and on my examination I could see that there were weak lower limb flexors as well. So this increases my it makes your differential diagnosis even stronger that it's an upper motor neuron cause. And also you'd find hyperreflexia, so brisk reflexes, and also the Babinski scan as well. So if you go to the lower motor neuron, so this would be the next category, and then you're thinking about the pathway again. So it goes from the anterior horn cell to the nerve roots, to the plexus, to the peripheral nerve, neuromuscular junction, and muscle. So again, so when you're doing the examination, you're always thinking, so the examination, you should be, doing it, you should know the examination like very quickly. You should be well practiced. So you don't need to think about doing the examination. You know what is next. So as you're doing it, you're thinking, okay, what is the diagnosis? What is the diagnosis? Where is the impairment? And making a note of the distribution and recognizing the pattern. So it was anterior horn cells such as motor neuron disease, it would be affecting the nerve roots, and there's no sensory deficit, so it's just motor only. And it's plexus, you're thinking very likely in PACES exam it would be the brachial, the lumbar sacral. If we're thinking the proximal nerve group, so you're thinking myopathy. And then if the distal nerve groups would be more like peripheral neuropathy. And then specific muscle groups would be specific dystrophies like Duchenne or myotonic. If you're thinking fatigability, then you're thinking neuromuscular junction, so mostly myasthenia gravis. And then a lot of the times you'd see in your lower motor neuron exams would be wasting, atrophy, and fasciculation. So that's very key for finding, for example, motor neuron disease. Hypertonia. So actually hypertonia is obviously something that you think, okay, if it's hypertonia, then it's lower motor neuron, but it's actually very, very hard to determine. So hypertonia is much easier to elicit, whereas hypotonia, I'd be a bit cautious. You'd be like, okay, unless you're very, very certain that it's lower motor neuron and hypotonia, I'd be like, I wouldn't really say that this is definitely hypotonic. Weakness and also areflexia as well. So the next category is cerebellar. So if you're thinking cerebellar, it might be because, you've asked them to walk and you found a very ataxic gait, for example, then you can do, if you have time at the end, you can do the extra test and show that, oh, I'm really, even though they've asked you to do a lower limb examination, you can be very sure that it's an ataxic, and you can be, you can sort of show off and be like, okay, I think this is cerebellar, so I'm going to look for all the other findings as well in the cerebellar exam. And obviously, if those are positive, then you can be, clearer that it's a cerebellar cause. So dysdiadokinesia, rebound phenomena, as we've said before, ataxia, nystagmus, intention tremor. So what you do is you ask them to go to the one place, and then you make sure that they stretch, so it's not just like this and they just bend it, and it's very, very easy. You put your hand finger out, not so far so that they have to lean over and maybe fall, but just a little bit, so they're definitely stretching to touch your finger. Staccato is slurred speech. Hypotonia, as we've said before, is very tricky, but hyperreflexia as well. And then we can think about the differential diagnoses. So, it could be due to alcohol, it could be paraneoplastic, multiple sclerosis, as we've mentioned before, it could be due to a tumor, Friedreich's ataxia, and then drugs such as phenytoin, hypothyroidism, stroke. So, I haven't put it in surgical sieve way, but as you can see, it could be so many causes, which is why having a structure and having a systematic approach is really, really key. And then if you have a surgical sieve, then it'll be easier for you to not forget any of the differentials. So extrapyramidal, so that again, if you think that this patient has an extrapyramidal category, you should be very happy. It's very, very common, and you should be able to have practiced this. So it's a group of Parkinsonian syndrome, so it's definitely important to know the differentials and how to differentiate them, because that's probably a question that they ask in the Viva. What are your differential diagnoses? So your most common but most likely would be idiopathic Parkinson's disease, but also you can mention, but it could also be, drug-induced frontal temporal dementia or corticobasal degeneration, PSP, and then you can say, but it's not likely to be this because, etc. So often, again, it's a very spot diagnosis, or they might say, oh, please examine this patient's gait and proceed. So then that's when they're not saying that, you need to do lower limb, only do the lower limb or only do the upper limb or cranial nerves. It's like, okay, you're going to monitor this patient's gait, and then you can think about what other tests you want to do. And that's when you can really show off and be like, I know a lot about Parkinson's disease, and then this is how I'm going to elicit all the signs for you. So in idiopathic Parkinson's disease, very often it's asymmetrical, and then you can see this tremor. So what you do is sometimes, the patients might be putting their hands to the side, or they might be hiding it, for example. So you can ask them, oh, do you mind just like resting your hands onto your lap? And then you can very often see the tremor, the pill rolling tremor. And again, this is the triad, so bradykinesia, and sorry, spasticity. I meant rigidity. So sorry, this is a typo. And always test gait. So even if you don't have time to test gait, then please make sure that you say that, I would want to examine this patient's gait, because if you see the examined gait, there'll be a stooped posture, there'd be a reduced arm swing, there might be freezing, and they're very small steps. So, these are all very pathognomonic for extrapyramidal cell Parkinson's disease. They might have hypophonia if you ask them, if you chat to them, you've asked them to talk, reduce facial expression, reduce blink rate. And extra tests, you could say that, I'd ask them to do some movements, or, check their writing, and it might be very, very small handwriting. And then also if you're, you think that, oh, this is Parkinson's disease, but I'm not really getting the symptoms, or you can ask them to use distraction so you can bring the symptoms out more clearly. So a lot of the time you can ask them to, when you're testing the tone for a patient, then you can ask them, oh, can you just like, draw on the like paint the wall with one hand, or if you ask them to do something, you can distract them by saying, okay, can you count backwards from 100 minusing 7 each time? So things where they're really, really thinking about doing something else, and then they're more relaxed, and then you can bring out their tone more. And then extra movement. So, and then these can be a combination of doing it during the exam, or during it, or you can say that you'll do it in the Viva. We can say, you can test the eye movements, look for PSP, check for any cerebellar signs, say that you're doing lying standing blood pressure, you'd want to check their medications, make sure that they're not having any medications that can cause these symptoms. And then you can ask, you do an ACE3 or a MOCA, for example. And then in the Viva, so, when you're doing the book work for practicing revising for PACES, learn the main drug treatments for Parkinson's disease, and the symptom management as well. How would you help for them, and very MDT based. It'll be, the Parkinson's specialist nurses, the OTs, the physios, etc. And you'll find that this is a running theme throughout the whole of the management for neurology exam. So lastly, cranial nerves. So again, there are so many cranial nerves, and there are so many different parts of the exam. It's definitely something that you have to learn and practice, and make sure that it's very smooth, what you're doing, etc. And you don't accidentally miss a cranial nerve because you're very, very stressed and, in the heat of the moment. So these are the main things, and I'm by no means a cranial nerves expert at all, but I think, you know, some things are very common and they might be very, very easy for to come in the exam. So you can think about, okay, so if it's a unilateral and it's affecting the third to the sixth nerve, then we're thinking, okay, this is likely a cavernous sinus lesion, and then you can think about the differentials for these, which are on the screen. And again, if it's cranial nerves 5 to 8, then it's more cerebellar pontine tumor, and then what would be causing it for that? And if you find that if it's acoustic neuroma, and if it's both sides, then you can think about whether it's neurofibromatosis. And then if it's unilateral 9 to 11, and then it's more jugular foramen lesion, and then you can think about different differentials for this. But again, you know, it's something that you just have to learn and practice, and then but I think because it's so, you know, and these are the main categories, so learn like the most common things for the cranial nerves, but I wouldn't worry too much about it, especially because, you know, you might not definitely get a cranial nerves exam. It might be upper limb or lower limb instead. And then again, if it's cranial nerves affecting 9 to 12, then think about bulbar palsy, MND. So very common cranial nerve palsy. So if you think about a third nerve palsy, you know, they'll present the signs of beatosis, you know, the eye will be looking down and out, and look carefully to see whether there's a pupil involvement. So if it's pupil sparing, it's more likely to be a medical reason, for example, diabetes. If the pupil is dilated, then we're thinking, okay, is it parasympathetic nerve damage? So in which case it'll be surgical cases as well. And then if it's medical causes, and you think about, okay, what are the things that we would want to do to check diabetes, for example, blood sugar, blood pressure, etc. If it's surgical causes, but either way, we would want to do a CT scan, look at the CT head, look at the blood vessels, and you can manage it by using prism glasses as well. And again, if it's a sixth nerve palsy, then we want to check for papilledema. You know, they won't be able to adapt the eye, and it might be a false localizing sign. So, for example, in cases of raised intracranial pressure or a cerebellar pontine angle lesion, as we've said before, you know, hypertension, diabetes, etc. And again, very common cranial nerve palsies, the seventh nerve, so the facial nerve palsy, and then when we think about that, we think, okay, you can do, you know, you can already see it's like a spot diagnosis, and then when you're doing the exam, you're like, oh yeah, unilateral, etc. We can see, and then you'd think about the differentials. So the most common would be Bell's palsy, but then you'd want to think about all the other ones, such as Ramsay-Hunt, if it's affecting the ear, diabetes, sarcoid, etc. So less common ones as well. So running through this is like a very brief overview of the very most common presentations, or, you know, common cases that we might see in the PACES exam. So myotonic dystrophy. So again, that can be, you know, you can already, if you look at the patient from the end of the bed close, you might already get the diagnosis, and then you can think, okay, I'm going to ask them to like open their eyes very quickly, or, you know, open their hands very quickly, and then see, you know, and then that can help you with the diagnosis already, especially because these patients are very common in PACES, even though they're not very common in our clinical life. So, you know, you see this ptosis, a lot of the time they have the frontal folding and the myopathic ACE. So, you know, if we go to causes, or if we, you know, maybe you might see these patients on our ward, but if not, you can always definitely Google them and see, you know, try and recognize what the patients look like, and you might see lots of wasting, especially in the lower half of the face as well. So these key exam findings, so we'll find a slow releasing grip, as we've said before, slow iron opening, so it's very myotonic, and you'll find wasting, it's more distal, weakness, absent ankle jerks, and then very slurred nasal speech as well, and percussion myotonia if you tap on their thenar eminence here. And again, association. So, you know, if you've got a lot of time, these are things that we can definitely impress the examiners with, or again, they might ask you, oh, you know, what are the associations with myotonic dystrophy? And then you can say it's associated with diabetes, and then you're looking for any signs of that. You know, let's associate it with the AV block and cardiomyopathy, look for any pacemakers. And again, look for cataracts. You can also say associated with hypogonadism as well. And then these are so you can think about, okay, so what are the associations? So therefore, these are my investigations. And then for myotonic dystrophy itself, it would be EMG, and then you'd find, very commonly you'd find dive bomber potential. So it's very important to know that it's an autosomal, so it's a trinucleotide repeat autosomal dominant condition with genetic anticipation. And they might not necessarily, want you to know in so much detail, but definitely knowing that at least knowing that it's an autosomal dominant condition is, probably something that they would expect you to do. And then you'd think about the management. So again, MDT, genetic counseling, and for the myotonia itself, you can use phenytoin. So hemiparesis, so we sort of already touched upon that, but again, from the end of the bed, you probably already have be able to get the diagnosis on inspection. There's a pyramidal distribution of weakness. You might see contractures, wasting, an asymmetrical facial droop, and it's more likely upper motor neuron size. However, if it's an acute presentation, it might be more like weakness and flaccid, so more like lower motor neuron size. But I mean, I very doubt that you will see patients in an acute presentation of hemiparesis. Definitely be more chronic, but it might be good something to note. And then if you're able, you can, do extra tests, such as, unless, if you haven't done the cranial nerve exam already, you can check that, and it's forehead sparing because of the dual innervation. You could do eye exam, speech, and then looking for associated risk factors. So, checking the pulse, checking for any AF, any carotid bruise, looking for diabetes, etc., looking for signs of anticoagulation. And the gait would be a circumduction gait. So, the most likely diagnosis would be stroke, and then you can think about other stroke mimics as well. And again, in the fibre, they probably expect you to know the classification of stroke and the assessment, or, how you assess the patient. So it'd be the NIH score. And then I think, because they the PACES exams, they want you to know that you're a safe, you're a safe doctor, you're a safe medical registrar. So it's very important to, in the acute setting, how you're going to manage the stroke. So if you suspect a patient with a stroke, it's you need to know the onset of the time. You need to know how you're going to refer to HASU if you're not in a HASU unit already. Make sure that they think about the 4 hours for thrombolysis, etc., etc. So that's really, really key. And then just make sure that in a structured way how you're going to present that, and be like, okay, if I suspect that this patient has a stroke, blah, blah, blah. And then you think about, again, the subacute management. So, if it's outside of the thrombolysis window, is it in the thrombectomy window? Otherwise, how would you manage this patient in the acute stroke unit? And again, both acutely and chronically, it'd be very, very MDT heavy, but also thinking about all the risk factors. So, if it's a young stroke patient, how are you going to investigate them? If it's not a young stroke patient, you still want to do an echo, 24-hour tape, etc., looking for AF, etc., etc. And then extra things you can know that really impress examiners would be, okay, but what are the contraindications to thrombolysis, etc. So if you have time, then those are things to talk. Might be things that they might ask about. So motor neuron disease, again, a very common presentation. So there's, as we've said before, mixed upper and lower motor neuron size. So if you're getting those in your examination, then that's when you're thinking, okay, could this be motor neuron disease? And obviously it's just motor. All the sensation would be, the sensory exam would be normal. Look specifically for wasting, fasciculation, look very, very closely, and also check the tongue as well. And very often you're getting, a mixed sign. So you can have absent reflexes, but upgrowing planters, hypertonia, hyperreflexia. You might have clonus and the Hoffman sign, which is when you push one of the fingers, your thumb reflex, and then reflex as well. And again, it's very, very MDT heavy. You're using so it's not only the neurology doctors, but also respiratory, gastro, feeding, all of that. And also be aware that how to manage a patient in an acute setting if they become very unwell, especially respiratory compromise. And mostly it's MDT, and then you can talk about riluzole as well as a drug treatment. Peripheral neuropathy, again, a very, very common station, and as the same as before, inspection is so key. Look for all of these things: walking aid, any wasting. You're more likely to find it in the distal rather than the proximal. Proximally, and then you look for fasciculations maybe, and then you can also look for sarcoid joint ulcers, finger prick marks. So those are very specific for, okay, what's the most common cause of peripheral neuropathy? Oh, okay, diabetes. Then you're looking for signs of that. Any chronic kidney disease, for example. If you're worried about, alcohol causing peripheral neuropathy, then you're looking for Dupuytren's contracture. So all of those things. So you can bring all the things that you've learned in for every single one of your exams for PACES, all the things, and then bring it together, because you want to pass PACES overall, and you want to be able to pass all the stations and get as many points as you can. So again, for gait, are we thinking about, is it very broad-based? Are they stomping because they can't feel, because they've lost their proprioception, they can't feel the floor? Check for rhombics. And sensation, that's really, really important in peripheral neuropathy exam. Make sure that you're checking both sides, you're checking all modalities, and you're checking the back of the leg as well, and check distally to proximal. So instead of going proximal and then checking all the dermatomes, make sure that you're checking from distal and then going up and being like, okay, does it feel the same both sides? Does it feel the same from here to here? Does it feel different? Is it getting more and more stronger, etc.? And again, there are so many different causes of peripheral neuropathy. So this is when the surgical sieve is key, and be systematic and think about what is the most likely diagnosis. So for example, if you see, signs of diabetes, then you wouldn't start with everything else. You can start with diabetes first. So you can say, like, my most likely cause of the peripheral neuropathy is diabetes. However, other differentials are. And then, as well as using the surgical sieve, you can think about A, B, C, D. That's another way. So, alcohol, autoimmune, B12, cancer, chemo, drugs, and then think about some of the common drugs causes, so amiodarone, cisplatin, etc. And then the investigation, so you can go on a long time because there are so many causes. So just think about your most common differential first, and then think about what are those different how you're going to investigate the patient to look for the cause of the peripheral neuropathy. And again, management is MDT, and obviously to treat the underlying cause. So MS, multiple sclerosis, again, a very, 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 very common station. So look carefully, any mobility aids, any signs of catheter, which might indicate a more severity, more severe multiple sclerosis. And the exam findings are more upper motor neuron signs, cerebellar signs, and sensory is more affecting the dorsal column. So you'd be looking for reduced vibration and proprioception. And again, eye exam. So eye exam, even if you don't have time to do it, is actually very, very relevant, and there might be loads of eye signs. So if you don't, you can say that, if I were to do, I would like to complete my exam by doing a cranial nerve exam, and there I might find signs such as an RAPD, so relative afferent pupillary defect, optic atrophy, INO, reddish saturation, etc. So lots and lots of eye signs. So if you do cranial nerve exam, you find those signs, and then also cerebellar signs, and then it's very likely to be multiple sclerosis. And then you can also talk about, ask about whether there's any Uphoff's phenomenon or Lermit's phenomenon as well. And then you can know the type. So, be like, okay, my differential would be multiple sclerosis, and then these can be categorized into different types. So there's most common as relapsing remitting, but also they could be primary progressive, secondary progressive, etc. And then they'd be like, oh yes, a lot about multiple sclerosis. And then other points of different discussion would be, it's very specific, the types of how we're going to investigate the patient. So, the lesions, if you do an MRI head, you find these periventricular white matter plaques, and the lesions are very specific, even in the history that they're disseminated in time and space. And that's, the key phrase for them to hear. And then you do an LP, and you look for paired oligoclonal bands as well. And again, management. So management, you can split it into acute and then in chronic, but always use the MDT regardless. Talk about in acute relapse, you talk about steroids, and then in the chronic, you would it'd be under a tertiary neurology care, and it'd be using disease modifying agents. And then it's really important to talk about the symptom management. So it's not only about, you know, the MDT, etc., but also think about all the symptoms that they could have, and then managing those as well. So pain, spasticity, mobility, bowels, bladder, etc. So again, it's very MDT based. And then you can think about other different, so, you know, you could be very sure there's multiple sclerosis, but think about other causes of demyelinating conditions as well. So spastic paresis, so this is a very whistle-stop tour, but so next one is spastic paraparesis. So again, these are more upper motor neuron signs. If you ask them to gait, it would be a scissoring gait, and looking for walking aids. And here it's very key to look for any sensory level, and again, looking for any spinal scars as well. And if there's any extra tests, extra time, then you can do a quick eye examination to look for similar things, as we said before. So differential diagnosis, so this is more of a myelopathy, so you think about MS, so as we said, and then also spinal cord compression, myelopathy, and what are the causes of myelopathy? Could be infection, trauma, etc. Like an abscess, for example, you'd want to look for MND, have any hereditary causes, hereditary spastic paresis, especially if there's a lot of atrophy and it looks like it's been going chronic, it's very chronic. Friedreich's ataxia in more younger patients, and subacute degeneration of the cord. And one of the key findings for that would be absent reflexes and upgoing planters. And the investigation, especially if thinking of myelopathy, is very important to do an MRI spine, but also you can do an MRI head if you're thinking it's higher up. And in spine, so and then if you're thinking it's a spinal pathology, so myelopathy, then you could, you know, if you're thinking like it's malignant or if it's trauma, then it's a medical emergency. And then again, they want to see that you're a safe medical registrar. You know that you're safe. You're safe to look after the whole take at night, the whole hospital at night. So they would want you to think about how you're going to focus on the acute things. So if it's a spinal cord compression, then you think about urgent decompression, speak to neurosurgery, and if it's due to malignancy, then you start them on high dose steroids plus or minus radiotherapy. But again, you know, escalating it up, talking to neurosurgery, etc., is very, very key. And again, you know the dermatomes, you know, so then you can differentiate what the sensory level is. Proximal myopathy, so we're testing, so specific, so again, you would do the test and you do the examination as you would do, and then so specific to check for proximal myopathy is to try and ask them to raise their arms above their head and see whether they can do that, or again, ask them to stand from sitting with their arms crossed and not using their hands at all. So just check their thighs, check their gait, check their neck, flexion, extension, and then looking for any skin changes. So again, this is to look at what are their causes, so what are the differentials. So it could, you know, as you can see, there's a very, very long list. It could be inflammatory, could be poly or dermatomyositis. So if you see that, then that's when you're looking for, you know, Gottron's papules, you're looking for any heliotrope rash, and this is when, you know, when inspection is very key, you know, looking for any signs of lupus, systemic sclerosis, any paraneoplastic, could be paraneoplastic, could be caused by drugs. So you're looking, do you know the Cushingoid? Are we worried about Cushing's, acromegaly, etc., causing the proximal myopathy? Any signs of liver or renal failure, and again, could be congenital as well, so muscular dystrophy, mitochondrial myopathy, and then also neurological causes of proximal myopathy, like MND, GPS, etc. And again, the investigations are based on your differentials, and then you'd also do EMG and nerve conduction studies, and you'd find myopathic changes. And also very often, especially if you're thinking like dermatomyositis, you do an MRI and then also muscle biopsies. And again, you treat the cause, but you know, it'd be long rehab, it'd be OT, PT, MDT, as said before. So Friedreich's ataxia, so you're looking, most commonly it would be a very young patient, so a young adult, so the onset is in teenage years, and you're looking for a patient in a wheelchair. And then you're looking for things such as an ataxic gait, pes cavus, indicating a very long-standing ataxia, bilateral cerebellar ataxia, so cerebellar signs, leg wasting, and again, absent reflexes and upgoing plantar. So if you see that, then you've got differentials of, okay, these are my signs of absent reflexes and upgoing plantars. What are my differentials for that? And sensation would be, again, loss of vibration and joint position sense. And then you're looking for these associations with Friedreich's ataxia as well. So kyphoscoliosis, optic atrophy, looking for high arch palate, sensorineural deafness, diabetes, and it's autosomal. Oh, sorry, I've just said autosomal inheritance. So again, it's, and the next one is neurofibromatosis. So we want to, if you're seeing neurofibromas, then you're thinking, okay, look for the other signs. So you do the examination as normal, and then you look for the other signs. So neurofibromas, cafe au lait patches, axillary freckling, niche nodules that you say that you'd look for, and then you see whether there's any palpable nerves, optic glioma. So those are things that are very key in the inspection. So, you know, and then you can also, and they'll ask you, oh, even if you didn't actually see any or you didn't have time to look for them, they might ask you in the viva, okay, so what are the other things that you would expect to find on inspection, etc. So those are, if you think it's no neurofibromatosis, especially because these are the things that they ask for a diagnosis, and then you should know these and be able to wrestle off them in the viva, even if you didn't have time to look for them. And complications, so scoliosis, epilepsy, and my patient actually had scoliosis, that one with neurofibromatosis. So again, you know, if you ask them to do a gait, and then you can see and looking for that if you're thinking it's neurofibromatosis. And then associations, so hypertension, because it could be associated with pheochromocytoma, renal artery stenosis, and lung fibrosis. So even if you don't have time to sort of like do that, and they probably won't expect you to listen to the lungs in a neuro exam, for example, but you can say that you're going to do that as well. And it's an autosomal dominant inheritance. And there are two types. So it's type 1 is a peripheral form. That's the one that we're most likely to see. It's very cutaneous. And then the second form is more central. And then you can also look for bilateral acoustic neuromas. And again, it's very MDT. So flaccid paraparesis, so this would be more lower motor neuroscience. Check for any difference in leg length, and look for any, you can look for wasting, and both, even if you're doing a lower limb exam, you know, look for any wasting in the hands, look for any ptosis, look at the eye movements, any fatigability, scoliosis, and looking for other clues as well. So, you know, you can see that it's very, very key is the inspection. And then we can think about what are the differentials are, different causes. So it could be MND, polio, cauda-equina, Charcot-Marie-Tooth syndrome, myasthenia gravis, spina bifida. And then if you think about polio as well, so it's more older patients and it's motor only, and there's long-standing weakness, so it's associated with limb shortening. So if you see that it's, you know, a very older patient, and you see these on inspection as well, then you can think of polio. So myasthenia gravis, fatigability is key. So you can already inspect, you know, is there bilateral ptosis? Is it fatigable if you check their eye movements? You know, you can look for any thymectomy scars. So examine, so you check for any so you're looking for ptosis, any extraocular muscle palsies. You know, if you ask them to smile, is there a myasthenic snarl? Is there any bulbar movement? So, you know, when you ask them to talk, is there any nasal speech? And there's proximal arm weakness and fatigability. So if you do that, if you're doing an upper limb exam, you're worried about, or you're thinking about myasthenia gravis, and what you can do is you can compare both of them. So you ask one patient, you can ask them to rest one arm, and then you could do fatigability with the other arm, and then you can test the weakness, and then you can see that there's a difference as well. And then again, you can ask them to count numbers in one breath. Again, that can check for fatigability, and then you can hear for the nasal speech as well. So very important again. So especially the patient won't have a myasthenic crisis during the exam, hopefully, but again, you can say that, you know, if you're managing the patient in the acute setting, you have to monitor for respiratory compromise, check for myasthenic crises, and especially, you check the FVC, so forced vital capacity, and you think about associations, so they do have any history of any other autoimmune conditions, and key differential diagnosis would be Lambert-Eaton myasthenic syndrome, so LEMS, but that's more paraneoplastic, so you can look for any signs of any especially small cell lung cancer, any previous scars from any surgeries, and that's more lower limb girdle weakness. And the reflexes are brisker after exercise, so that's one of the key differentiating factors. And then for LEMS as well, it's anti-calcium channel blockers. Another differential would be mid-efficient variant of GBS. So for myasthenia gravis, the investigations, it's anti-acetylcholine receptors, and that would be testing in the serum, and that's in 90% of the cases, so most of the cases. And then otherwise, you can check for anti-MuSK antibodies, so anti-muscle specific kinase antibodies, and do an EMG as well. So again, MDT, specialist neurology input, and acute, you do IVIG, plasmapheresis, and chronic would be immunosuppression, thymectomy, which even if they don't find a thymoma, very often they have thymectomies, and they find that actually patients are improved and they're getting better with their myasthenia gravis, and also protohistamines long term. And also, very importantly, is drugs to avoid. So you want to avoid these medications because they can cause myasthenic crises. So there are definitely things that you should be aware of. For example, certain antibiotics, beta blockers, anesthetic agents. So again, those are things that would really impress the examiner if you mention them and they think, oh yes, this person really knows what they're talking about. So Charcot-Marie-Tooth, so that's also known as hereditary motor sensory neuropathy. And again, inspection is key. You can see that's a wasting of the distal muscles, but the thigh muscles are more preserved. So people say that it's an inverted champagne bottle appearance. Again, you can see pes cavus because it's a long-standing condition, and there's weakness of the ankle dorsiflexion as well. And if you ask them to test the gait, high stepping gait, stomping, because of the sensory neuropathy. And it's very variable, but it's most likely the stocking sensory loss, but it's not sort of variable as to where the deficits are. And again, looking for their walking aids, whether there are any splints, whether they're using any walking sticks or mobility aids, etc. And there are two types, and again, it's an autosomal dominant condition. Okay, so those are a very, very quick run through. So they're very brief overviews. So I'm sure hopefully you'll get to see some of these presentations. You can think about, okay, what are my differentials, and how, think about these very common cases. So again, when you're presenting, so just to go through it. So when you're presenting, you're thinking about it when you're doing the exam, and then you're thinking about, okay, where is the lesion? So what is the category? Is it upper motor neuron? Is it lower motor neuron? Is it affecting both only unilaterally or bilaterally? Is it symmetrical? Is it asymmetrical? Is it proximal? Is it distal? So if you can already, even if you're not sure of the diagnosis, you can say, I believe that this patient has an upper motor neuron lesion that is affecting unilateral only, and it's affecting both proximal and distally. There's no difference. Then they can already see that, okay, you've examined a patient before, you know what you're talking about, you've found the right signs, and that's one of the key things in the battle. And then you can say, okay, so this is why I found this, because I found that there's, for example, an asymmetrical facial droop, or there was hyperreflexia or whatever. So, just talk through your key examination findings, so the main positives and the main negatives, and then think about other things that are alluding to the severity of the complication. So, you can see a PEG tube, or you can see a catheter, or you can see mobility aids, etc., leading, indicating the severity. And then because you've said all this, and then you say, okay, so therefore this is my differential diagnosis. And unless it's like, for example, if you're thinking it's a peripheral neuropathy, then you can talk about, and the underlying etiology of this peripheral neuropathy is likely, and then your investigations and management can be based on that. So the last tip, so as I've said, it's not an exhaustive list. It's just a very brief overview and just useful tips that I've learned during my PACES examination. And, they don't expect, it won't be a neurologist that's being the examiner, and they're not going to expect you to know every single thing about neurology. And they know that it's a very, very hard examination, and 4 minutes goes very quickly. So after you've presented, you've told your findings, and then you've said that these are my differentials because of this, they don't have that much time to ask you very specific things about the genetics or whatever. They want you to make sure that you're safe. You can find the findings, you can do a neuro exam, and you know who to refer to. You can make sure that you're getting the MDT involved. And also read the instructions very carefully. What are they asking you to do? Is it a very specific system? Are they asking you to test the eyes, etc.? Or is it gait and proceed? So just make sure that you're reading them and you're following the instructions carefully, because this is what they're expecting you to do. Just break it down, localize the lesion, be systematic. So make sure you're practicing a lot. You've got this one standardized way of examining. So regardless of the patient, you know how you're examining, doing a very practiced neuro exam, and don't forget the MDT. So these are what I would recommend for resources and also my sources and reading, and you probably know all of these. So for me, seeing the patient doing examination is the best revision that you have. This is a examination practice. You've done, all the written exams. So bedside teaching practice is the most important. PACES courses. So I did the BitePACES course. It was really good. So, going onto the PACES course, seeing these patients, having examiners who've done it before, they know, and they can help you, and they give you these tips, and they can give you good feedback. I've used past test videos. Try and get to a neuro clinic if you can. Ophthalmology clinics, they're really, really good. Make sure you're looking at lots and lots of eyes. I use a pre-PACES podcast. If you haven't gone through that, that's really, really good on your commute. The Leeds PACES website, again, is really good for neurology. Cases for PACES, the BitePACES resource book, and also with thanks to my consultant as well, who taught me a lot of neurology. So again, that is the end. Thank you so much for a very whistle-stop tour. I'm going to just leave this on here just for the end, but thank you very much.
Thanks so much, Jackie. That was really, really good, and I'm sure everyone found that super useful. And I've linked the feedback form in the chat, so please fill that out, because that's that'd be really useful for Jackie. Please do fill out the feedback form. And if there are any questions, do let us know. I think we had a pretty good turnout, almost 50 people, and nothing coming through at the moment. So thanks a lot, Jackie. That was really helpful. What I'll do is I'll also circulate the feedback form out to people in our WhatsApp group, so they can fill out in case they missed it in the chat. Okay, fantastic.
Thank you all, and good luck. All the best.
Fantastic. Yes, please do tune into our following webinars. We'll post information on the WhatsApp group, fill out the feedback form, and we shall hopefully see you at our upcoming courses where Jackie will also be teaching. But till then, everyone, take care and have a lovely evening. Thanks a lot, Jackie, again.